call. We have a few people still logging in, so we'll give just a few more minutes for those trying to join. We'll be back with you shortly. Any additional people trying to hop on right now, so let's just get started and we'll welcome people as they join us during our call today. So welcome to another monthly coaching call for the HIV Continuum of Care Collaborative. I'm Kathy Rhymes. I'm a faculty member of the HIV Continuum of Care Collaborative, led by the BC Center for Excellence in HIV/AIDS, and made possible by the hard work and passion of all health authorities and many community groups across British Columbia. I'm happy to be facilitating this call, the sixth call in a series of 12 monthly calls that will occur between now and January 2015. And the purpose of these calls is to provide collaborative participants with space to share good ideas, find support through the challenges, and connect with each other to further our shared aims. So it's really important that these calls are relevant and useful to you. And to that end, we hope you'll speak up. We have plenty of opportunity to have dialogue today, and we welcome sharing your ideas, your challenges, the questions, and the lessons learned so far. In today's call, we're going to focus on thinking at a population level, and we're going to really frame the call around two key questions. So first, the conversation about what have we learned about our population, and then in addition to that, how have we used that learning to develop system-level changes for our organizations and centers, those things that we've made to date and perhaps those things that we have on our minds. So I'm going to start just to share a few ideas about how thinking at the population level can drive system change. And then we're going to look at the diversity of the populations of focus across the HIV Continuum Collaborative. In other words, the populations of focus that you each have chosen. We'll look at those in more detail. And then I'm hoping that you'll share your insights about what you've learned about those populations and how you're thinking about making changes based on those learnings. And we want everyone to be able to know how you've been thinking. Certainly there's a lot of overlap in the populations, and what you're doing in your organization is really relevant and helpful to others on the phone. So we really hope that you'll speak up so that we can have a rich conversation and get lots out of this call. So let's jump right in. And the first thing I want to just say up front is we're going to be talking at a population level, but all of us know that healthcare should be personal. And it's our mission and what we do every day to make sure that healthcare is the best it can be for every individual that we serve.
We just need to look at our to-do list to make sure.
With that said, we also know that healthcare improvement can really be driven at a population level. So in other words, even though we want high-quality care for each patient we serve, we know that things like how we're available to people, what our appointment is like, or how we're available on the street, for instance, how our phone tree works. You know, is it personal or do you have to push many, many buttons? Our new patient orientation process, our ability to meet the needs of our patient and provide those services at our organizations. All of those systems that we put into place to serve patients really benefit each patient, but also every patient. So the concept and the paradigm shift between thinking about each patient that we serve to this population level is really important. And I like to think about it as two different drivers. So the first one is we go from the patient in front of us or the person in front of us how can we make the healthcare the best it can be, to thinking at the system level, how can we make healthcare for everybody in our population the best it can be. So it's a from one to one to many, if you want to think about it that way. The other thing that thinking at a population level does by nature is it really changes the dynamic. So again, in our profession, we often will serve that person in front of us. What's their need? How can I meet their need? How can I help this person to move forward? Thinking at a population level is more proactive. So we're planning, how can we make system changes that are going to positively benefit all of the people in our population? And again, there's room for both in the care that we provide. So we want to meet the needs of individual patients, but we also know that we can leverage a lot of good and a lot of positivity for all of our patient population if we think in those higher level terms. So those are the two drivers, the way that I think about it. And let's look at an example or two of how moving from individual transactional care to population level can really benefit us. So just a couple of examples, and I'm sure you have many more, would be if a patient comes in to a clinician and they're being seen for a visit and the provider orders a viral load for that patient. One way to improve, and I know many of you have done this, is to create standing orders so that every patient that comes in for a visit has the opportunity to get their viral load measured on time. And many of you are thinking in this way, and it's not just viral load, of course, there's other labs that occur periodically for patients that are HIV positive. So making these systems reliable so it doesn't depend on someone remembering to order the test, but rather it happens at a system level. Another example, and many of you are experimenting with this as well, is referral to pharmacists. So again, the old paradigm, if a patient was struggling with adherence, for instance, or a patient was concerned about side effects, or the provider was concerned about drug interactions, there might be a referral to a pharmacist in that particular instance. But we know from our work with our colleagues in pharmacy that they have a lot to offer our patients. So if we have the resources and we can create the partnerships, having pharmacy services available for all of our patients would really benefit the population. And likewise, newly diagnosed patient, we're lots of times confronted with a very, it's a very powerful kind of situation where someone's been newly diagnosed. It's clearly upsetting news, and we're in a position perhaps to link this person with a physician for the first time. And many times that can be done in a reactive way, and has to be done in a reactive way. But some of you are experimenting with, well, how can we make this process easier to navigate? How can we really codify the process so that we know the steps, we can be reassuring to this newly diagnosed patient, and to the extent possible, give them options for care? How can we link a patient to a clinician that's going to match their needs and what that patient is really looking for in their care? And then finally, just thinking about any urgent situation as they present. So many of you have focused on populations that have a great deal of urgencies, either mental health needs or housing needs or food insecurity. And so you're confronted fairly often with patients who have a need that should be addressed fairly urgently. And many of you are thinking ahead and providing perhaps an acuity tool so you can anticipate those needs. Some of you are surveying some of your populations to find out what the needs are so that you can address them at a population level. And I know many of you are thinking in this way already, and so these are just a couple of examples to illustrate the point. But again, I think you can see that system changes can benefit many of our patient populations and take us out of that reactive mode, allow us to be more proactive in the overall scheme of things. And so these are often a way to think about the system changes that are going to be most meaningful for the populations that we serve. So let's just take a look, and many of you perhaps haven't seen our populations of focus presented in this way. It actually took a couple of slides. This is slide 1 of 2, and this is the diversity of the populations of focus in the HIV Continuum Collaborative. So you can see that there are people who don't even know they're infected, to inpatients, to comorbidities. Um, Sometimes it's all of the HIV patients that are being cared for. Sometimes it's a subset. And you can see the diversity. All of these patient segments in the areas that they're being focused upon are really relevant. So in some areas of British Columbia, there's not adequate access to care. So you're looking at all of the patients, all of the HIV patients. In others, you are focused on populations that have really been difficult to engage. So those who are street entrenched or addicted to substances. So you can see there's a great diversity of the population of patients that you're focused on. And if we look even further, we've got perinatal, again, those marginalized populations. I think it was really intriguing that there is a team, and I think many of you are thinking this way, thinking about those that aren't connected in care. How do we even find those people? And how can we create systems within our organization to find those people and embrace those people who may not be connected to care, but they're in our service area or they live in our neighborhood? So all of these are the populations that you have identified, the ones that you're interested in focusing on. And what I hope to do at this point is to invite you to have a conversation about what you've learned about the population that you're focused on, and how are you thinking about at a population level with those two questions that we started with. So first, what have you learned? Maybe some things that are surprising, or maybe you've verified some things that you had a hunch about, but you've been thinking in this way for a little bit now, so hoping to understand what you've learned. And then secondly, what are the examples of system changes that you are thinking about or that you've already made that will improve care or services at that population level? So Anna, I don't know if we're unmuted, but I think we can try that and see if people will speak up. Alternatively, if you'd like to chat in the chat box, we'd be happy to call on you. Someone's typing, which is good news, because otherwise you guys will be really bored. So while we have someone typing, is there anyone willing to share their population of focus? If you would just say who you are, your organization, and what your population of focus is, just as a context, because as you see, there's such a diversity of populations. And then perhaps a word about what you've learned or what changes you're thinking about. So in Interior Health, we've created an outreach nursing model to assist in accessing harder to reach populations. Terrific. So I don't know, JMH, I don't know that person. Are you willing to speak on the phone to tell us a little bit more about what you understood about your population besides them being harder to reach, and what made you choose that particular change, that outreach nursing model? I believe I've been told that there are some people that don't have a microphone that they can hear, but they can't speak. It looks like that's the case. So thank you, JMH. Also creating a network of physicians that are willing to take on HIV patients. There will always be a spot open for HIV care. Excellent. So what I take from that, and I'm going to just conjecture, so you learned that people that are hard to reach could be hard to reach in a couple of different ways. First of all, They may live in places that may be unaware or it's difficult to obtain routine care. And so you create an outreach to go to the individuals rather than waiting for them to come to you. And you also recognize that hard-to-reach patient populations don't always play by those same rules as wanting to go for an appointment at a certain time, especially if it's a couple of weeks out, and that making care more accessible to these patients by having a spot available and having a space available is very, very helpful to engage those populations. So if I don't have that right, please correct me. And Sam has a question. How are you providing training support to the physicians who are willing to take new HIV clients?
Hey, Victoria. How are you?
So JMH, that question is for you. If you
Hi, can you hear me?
Oh, yes.
Hi, it's Sam. So yeah, sorry, I was just going to pretend my phone wasn't working today, but I guess I'll talk. So my question to JMH is, in the north, we're seeing that kind of similar response. So when we're going and introducing testing to the more rural communities, kind of the first comment by the physicians are, we're willing to do this, but we've never had a client living with HIV before, so what are the services you can provide to us? Essentially, what are the supports? So I know what we tend to do is simply load them up with a bunch of resources, the BC Center for Excellence number, Dr. Homore's number, Jennifer Hawk's direct number, kind of resources they can access if they need it. We're trying to organize dinners and education sessions for them, but if there's any other ideas out there, I would love to hear it, especially the rural and remote doctors.
Thanks, Sam.
Yep. Sending them to a 1 or 2 week training session with BC Center for Excellence. Wow.
And offering funding to do that.
Wow. Nicely done. I like it.
Yeah, as a primary care physician, we have some rural places here in the States as well. That's a common concern because especially those of us who were trained when the epidemic first started, it was really complex and there were a lot of unknowns. And not to say it's not complex now, but we know so much more. And a training and some reassurance and some linkages to real-time help should you have a client in front of you that needs something beyond your expertise is very, very helpful.
Mm-hmm. Absolutely. And I appreciate what you said about real-time. And the struggle we have in the north is our real-time is not after hours, right? So in the after hours, we would refer to the BC Center for Excellence 24-hour physician line.
And I don't know if BC Center for Excellence or those who are on call, say at St. Paul's Hospital, have this. We have this in Colorado where there is the person that's on call in the hospital is willing to take remote calls in urgent situations. So in other words, if there is a child seen in rural Colorado that needs assistance from an expert, we can call the Children's Hospital in the middle of the night and say, hey, we've got this child here. We don't know what to do. Can you help us? So it's that type of setting. I don't know if support for HIV care is set up that way, but it's one model that could be considered.
You would definitely get like the IDC doc on call from St. Paul's. So you could access that 24 hours. I think, anyways. I've never actually had to do it, so maybe someone on the line can confirm.
Hi, this is Rolando, and yes, Sam, this is correct. So the Center for Excellence has the hotline that includes 3 different levels. There's the pharmacist hotline and also the family physician hotline and the specialist hotline. And they're all around HIV, antiretroviral therapy, and are provided to support mostly providers across the province. Now, I'm one of the ones who staff the line, and over the last few months, we have seen a significant increase on the number of calls that we're getting, particularly from Interior Health, so which is a really good news. The physicians are very keen in keeping their patients there and managing the patients. Questions are very appropriate in terms of management and treatment decision and so on. So that is available. In addition, as it's been pointed out, the Center for Excellence also provides that intensive preceptorship training, and it ranges from 1 to 3 months, depending of the funding available and the stream that the physicians choose to come and visit. Most of the time it's only 1 week, but more than the training or the learnings is also the exposure that they have to other services and other providers that they can connect in the future whenever they need it.
Excellent, thank you. And what a terrific example of a system change to build capacity in remote and rural communities to serve the population where they live. Excellent example. So who else has a population that you're working on that could share a little bit about what kinds of improvements and system changes are being driven just by the needs of that population and what you're learning? So is there anyone on the phone working with the population that doesn't know their status? So I'm assuming that that would be outreach for testing and perhaps linkage, that particular population of patients. Who's working with that population?
This is Port Alberni and Health Outreach. That's one of the things that we're doing. We found last year quite a number of new cases that had not been previously identified that were quite old, and so we're trying this year, particularly within the First Nations population, to do further testing and education and try to reduce stigma as well in order to promote testing.
Great. So understanding that there are some barriers to understanding your status, even to get testing, recognizing that stigma is one of those barriers that's really important, especially in some populations. Could you say a little bit more about what kind of education you found to be helpful to reduce stigma?
Nope.
Not yet?
It's a bit of a dream still, honestly. We're so swamped in terms of the workload trying to do all things to all people, and HIV is just one piece of what we're doing. So although we've had some educational tables at Aboriginal events, we're talking to doing some stuff together with the on-reserve nurses in terms of education and making our program available for testing. So people from remote communities, when they come into a bigger center like ours, then would know where to come more anonymously for testing than in their own communities. So we're really in the idea phase right now rather than implementation. We're running workshops with our high-risk population a couple times a year here where we talk about HIV a lot, and there's a lot more openness about discussing HIV, and that's mainly around prevention education. So that has reduced stigma locally to some degree, but we've got a long ways to go. So if anyone else has ideas for us, we'd love to hear it.
Terrific. Thank you. It looked like Paz had their hand up. Oh. Paz was exploring the options. Great. So, anyone else working on stigma? I think that's a really important characteristic of some of our populations. So, First Nations certainly, but there are other people that feel stigmatized just by having HIV. And anything that you've done system-wide or that you're thinking about doing that would be worthy of sharing, or perhaps there's a question in addition, anything that can help with what I'm sure is a very common theme across many of your work.
This is Sam. So we're addressing stigma as well. I don't necessarily think we're doing a very good job at it, and I think Janice is right that, stigma's alive and well, but so just a couple random thoughts. One, are now presenting to town councils, so we're trying to engage community leadership to start requesting the test and also bringing them up to speed. In the last 3 weeks, I've gone to 3 town councils, and the knowledge of HIV in the room was kind of firmly rooted in the 80s. I think we were still stuck in the Rock Hudson days of HIV knowledge when I was presenting to those town councils. And that presentation, each one of those, I didn't come across, my presentation was geared towards, this is where HIV is today. So I wasn't there advertising testing or the From Hope to Health initiative. I was just saying, this is where HIV was, and surprise, surprise, this is where it is now. And those presentations went over well, and I definitely got positive feedback, as in, I didn't know that, thank you for helping me learn. So that's happening, and we're also trying to host community forums. We have our second one in Burns Lake coming up in August, of where everyone in the community who's interested in HIV education can participate. So I don't know the turnout on that. I'll let you know how it goes in the end. But we're definitely just trying to get into the community. The other thing is I find that, and I've struggled with this for a while, is that healthcare itself stigmatizes HIV. So we tend to be focused on educating the community about healthcare, but I think we also have to look internally in and look at some of how we stigmatize healthcare. We stigmatize HIV, and work on that angle before we can truly expect the community to come on board.
And Sam, could you say just a few words about the stigma that you've observed within healthcare?
So part of that stigma is also attached to the clientele that is more likely to have HIV. So we're looking at marginalized populations, et cetera, the high-risk population. So the stigma attached to them, and so that transfers over. But I also look right down to the pre- and post-test requirements of HIV testing, of how that contributes to it. I mean, other than some genetic screening, what other tests do we get overly concerned about doing up to half an hour of pre-test counseling on? We don't really. We just kind of test them and deal with the follow-up. If we look at education and curriculum coming through nursing schools and medical schools, odds are they maybe have written one small paper on HIV, but odds are no. Their knowledge, if they have any, it's because they've wanted to get it. And then we also have kind of several or even from the routine screening, people we can, and this isn't necessarily stigma attached, but people who aren't necessarily buying in to the science that says, regular screening is effective, and so we're getting that resistance happening.
Yeah, that's really helpful, Sam. So this is a really excellent topic, and what I hear from this is that there are a lot of ideas, a lot of experimenting going on within the teams to try to crack this nut, and stigma is a really complex issue, as we've heard. And this is exactly the kind of sharing that we need to commit to continuing because we have a lot to learn yet on how to make this work. And there was a question about making inroads in communities. And Sam, what has been important to get you in the door to have this conversation, which is really an important one to have?
conversation get in the door into the community.
Yep.
I think it's linkages, it's relations. It's when Prince George, the hospital in Prince George was told that we were coming, and we've honestly really struggled with getting routine testing running in Prince George. It's been really hard. It's definitely increased a little bit, and the primary care homes in Prince George are probably where you're seeing the best increase, but in acute care, not so much. James Vanderhoof have shown increases because there's been that senior leadership buy-in. There's also been a recognition. So, and we were invited to these places. These aren't places we were saying, hey, we're coming there next. These are places who reached out to us and said, can you come and start this program? And so we did. And then from there, it moved to Fraser Lake, and we're starting it there, and then Burns Lake. So we were getting kind of that little bit of like overflow from each community into the next community, and it takes one person in that community, the right person, mind you, to invite us in, and then once we kind of generate that leadership buy-in, it's infectious on the way down. But I think a lot of it has to do with like the buy-in in Fort St. James was that the providers in Fort St. James have history working in HIV and also saw their numbers in the last year of the new infections. So they recognized it. And then that overflowed all the way up to Burns Lake with people requesting it. So the way into the community is not by us, it's by the community asking us and by word of mouth getting to them and them reaching out. And as far as the town councils and stuff like that, you just get on an agenda, they can't stop you.
Yeah, and that's been my experience as well, Sam. You're mentioning the people, and it just kind of spreads from there. And many times it can be a leader, like an executive leader, but just as often it's an opinion leader, somebody who is vocal in the community, who just seems to know everybody. People respect his opinion, and then he starts talking about the benefits or, something that was surprising or some things he learned about the population that perhaps people have had infections for a long time and didn't know it. And by doing this testing program, they were really able to be helpful to some citizens of the community. And that kind of thing takes off, and people listen to that in a very kind of heartfelt way, and that communication is very helpful. So we have a couple of other comments here. HIV education, greater presence in nursing and medical curriculum. Good point. And then policy will influence practice most, and I think this will reduce stigma by normalization. Oh, and I wish you could talk, JMH, because I think that's a great comment, and certainly normalizing how we care for HIV. I think some of that has happened certainly since HIV has become more of a chronic disease, but perhaps not always. And I would just love to know what policies that you're speaking of that might normalize HIV care.
Can I jump in there for a second?
Yeah.
Sorry, maybe I'm just being argumentative today, but I don't think policy truly influences practice. I mean, look at the HIV testing, acute care testing at the hospital here in Prince George. It's in. People aren't testing. Policy has done nothing to influence their practice. Unless we sway them emotionally or rationally or through the literature or through the evidence or somehow, that's what's going to sway practice, not policy. People walk right through policy. There's so many policies out there that we can't keep track of them all. So we can just bury this little HIV testing policy over here under the shelf under these 18 layers of books, right? That I don't think actually influences change on the larger level. I think it has to be buy-in.
So you're talking at that leadership quality that can lead with the head and what's reasonable and what's evidence-based, but also with the heart. And that requires strong leadership. And again, I do believe some emotional buy-in, but it would be an interesting debate about what comes first, the policy or the heart to follow that policy. So policies are helpful, in that they pave the way, but they're only as good as people actually follow them. I don't think there'd be disagreement about that. So then, Christina, universal policy as per CPHO direction. And I'm sorry, I don't know what CPHO means. Somebody help me. What's CPHO? And there's a lot of agreement that it looks like you've got to management support and make sure that that policy is followed. And I do agree with Sam that it's not just a stick. It's a carrot and a stick kind of approach where people need to understand the benefits of following policies. Sometimes it makes it easier to comply. Then Elena mentions frontline healthcare providers acting as gatekeepers without consequences to not following policy. Oh, and thank you for the Chief Public Health Officer. I should have known that. So this is a great conversation, and again, all linked back to what kind of system change can we make to help people understand their status, talking about testing and how important these system changes are, and yet how challenging they are, even once you have a great idea, how challenging it is to implement it reliably and well. And that speaks to the fact of policies not being followed or guidelines incompletely followed. So how do you pull people on board? And that's a lot of what you're experimenting with and learning is how to manage that change, how to get your, and it's not only the top leaders, it is that middle management also. We've got some increasing evidence to look at system changes, especially at an organizational level. Depends largely on that middle management ability to really convince frontline staff that the change is better, that the change is better than the old way of doing it. And they have to kind of sell it. So it could be better for patients, it could be better for the working environment, it could be better for the organization, but the managers need to connect the dots for the frontline staff. Because if it's just a policy and procedure on a dusty shelf under 18 books, like Sam put it, it's not going to be followed. So it's really up to that middle manager to convince staff that it's important to do it and to give that rationale in a way that makes sense. Stories of late catches with many opportunities can have impact. Yes, so I think what you mean is that the person has had HIV for some time and just now getting tested and already very ill, where if we could have caught it earlier, it could have had a much different outcome. And great contribution by Christina to remind us that these stories can be compelling and helping people understand the rationale of some of these policies and really making it personal. You know, we in healthcare and any service organization really care about those individuals that we serve. So making these stories align with what we're trying to accomplish on that system level is really, really important. So anyway, Christina asked, who else uses stories? Again, thinking about populations of patients, we're trying to make these changes. We're trying to get changes that are going to benefit the people that we serve. And those changes are hard to manage. So stories can help us. Who else uses stories? So we've got some people typing. I have another question and see if the folks are on the call. Who is looking at those in a particular area not already connected to care. I'm really curious as to what you've learned about that population of people, why they're not connected. So I'm assuming these are people who know they have HIV, but they have not engaged in care. Is anyone on the phone that could speak to what they've learned about that population? Meanwhile, we've got a couple of stories. Stories of recovery are powerful to demonstrate it's different now. Great comment. And at Keys, we're providing fun opportunities to come and connect. Have a barbecue and a magic show for World Hepatitis Day. Oh, that's great. Man, I want to come. British Columbia is beautiful this time of year. I want to come to your barbecue. Wonderful. Anybody working on that population that is infected but has not engaged in care? I'm just curious as to if there's any learnings that you could share.
This is Janice in Port Alberni. We have a couple that we're working with right now. Both of them are very much kind of conspiracy theory oriented, just very much anti-establishment in terms of the healthcare system.
Mm-hmm.
And although with the one we've done very well in developing a trusting relationship with our team. They're not trusting enough to start medication.
Mm-hmm.
But we've got a dialogue going, and ongoing blood work and ongoing doctor's visits. So, it's coming along. So I think our successes there have been very much through relational practice and just accepting people and taking a harm reduction approach rather than, trying to really push them into fitting into our pattern of things.
Yeah, that's a really nice point, and one that is important to keep out in front of us. So are these folks, do they have a mental health issue per se, or is it a lack of trust just around the HIV in particular?
I think both of them have some mental health issues as well. Nothing diagnosed at this point, but it, both of them, it runs through their entire lives. They're the way they operate. Yeah.
Well, that's great that you're making progress. It's a very difficult situation, and I love your approach of harm reduction because, at least my experience with those people, if you push too hard, then they're gone. So that's just building that trust by slowly and being patient is challenging, but a great approach. And Elena mentions in the early days lots of studies looking at provider attitudes to their populations at risk. I wonder if in health authorities outside the lower mainland there may be value in finding out the choices providers make regarding testing or not. Interesting. Elena, can you speak to that? Sorry to put you on the spot, but can you speak a little bit more to the what you mean by that? So looking at whether or not providers are testing and then exploring what's behind that decision, is that what you meant? Elena must not be able to talk.
I had to phone in. I lost the connection to the online dropped off, so I just.
Oh, okay.
So I didn't hear what the question was.
So you just typed in about the provider attitudes towards their population at risk, and so I was wondering if And you mentioned perhaps an activity where health authorities might find value in trying to understand. I think what you meant was whether providers test or not, and then what is behind those decisions.
Yeah, because there could be a whole range of everything from sort of a reflection of stigma right on through to that lack of confidence that the person has. And so if you're really busy as a healthcare provider and you can immunize a baby or sit down with a mom and talk about the fact that she's at risk for HIV and maybe she should have had a test, how you choose, you overtly you are choosing, how you spend your day. But if you are feeling uncomfortable or unsure of yourself, it is much easier to focus on immunizing the baby and not go to the next level of question. As just one example, because it also could be in terms of anybody who's working with someone with with substance abuse or mental health issues, not wanting to go any deeper into the question. You don't ask about HIV or risk around HIV. You just deal with a different level of the presenting symptoms, going the next step.
Yeah, I think that's a great point, and it re-emphasizes the importance of having support, both educational support and also real-time support for providers and clinicians so that they feel more confident. And I would go so far as to say patients pick up on that. So if a provider isn't confident, that makes the patient feel not so confident in that care as well.
Yeah, my personal experience has been a lot that way, because it's amazing the kinds of self-concessions I can get on airplanes and everything, just by I'll indicate that what kind of work I do, and the next thing I do, I'm getting a family member telling me about their son or their daughter or something like that, without, so that people pick up and they'll say, well, I've never said this to anybody or whatever, so that, and I can't say that I have the be-all or end-all of attitudes or anything, but I certainly am sometimes surprised the degree to which people are eager to talk if they get the signal that you're willing to listen.
Great. Yeah, I think that's a great point. And Christina, you mentioned that you've seen a team engage two providers. Just offering the data, that's another way that us quality improvers can be helpful. So if you're looking at the percentage of providers and how often they offer testing, and there's variation among providers, it's a great way just to bring that variation forward and to have them discuss it. And Christina, do you remember how they brought that conversation up to explore that the differences?
Hey, Kathy, it's Christina. I can't recall specifically how they started this cycle of change. I could certainly follow up, but I think you're right on. Just kind of shining light on things created sort of a springboard from which they were able to learn a little bit more about the differences in how the testing offer was being provided to people. And so from that, looking at the data, they were able to explore some of the differences and then compare over time when each of them sort of changed how they were doing that. And as a broader concept in terms of the question of what are some of the examples of system changes that can improve care, I think this issue of data and information systems has repeatedly come up as a ubiquitous theme in terms of how different teams use a population and then create some sort of system to be able to organize their data and information from which they can make decisions that will benefit that population.
Great, thank you. And in my experience, the variation conversation is particularly powerful among clinicians. It has to be handled in a non-judgmental way. So in other words, if you're looking at someone with a testing rate of 10% and 90%, you want to emphasize the 90% and emphasize the fact that, wow, someone is testing a lot. How do you do that? Instead of, why aren't you testing? So the conversation has to be positive, but framed in that way clinicians are naturally curious and competitive, and so they'll have a conversation among themselves and can be facilitated about, well, this is how I do it, this is how I do it. And clinicians, want the best for their patients, and many times that's all it takes is just understanding a better way of doing it. So there is actually a lot of literature out there looking at variation, everything from immunization to C-section rate to surgical complications, a lot of evidence to do just what Christina mentioned, bring the data forward and ask providers or others in a similar role. So you could ask MAs about their incidence of doing a task that an MA does and measure it and look at the variation and have the MAs come together and talk about it and understand a best practice within the organization. So again, a great technique using data to understand how changes may be implemented and also perhaps the best practice within your organization. So pretty cool. There is another thing I'd like to just follow up on quickly, and that is a problem accessing the names of individuals who have not accessed care, and you're trying to figure out who they are. And I'm wondering, is that a physician survey? I'm not quite clear what that comment is. Maybe the comment, the physician survey, is about the testing, what the attitude is for testing. But I'm wondering what is available in British Columbia to figure out who might have been diagnosed but not yet engaged in care. What is the current state of sharing that information, or how should teams be thinking about that? Maybe somebody can help me with that.
I can speak to that. It's just Kathy from Chilliwack.
Hi.
Hi, I didn't write that, but we've been working on that very thing. One of the problems is that we've been working with doctors, which is really great, and they are giving us lists of people who they haven't seen, like they've seen once in their practice and haven't seen for however many years. And our problem is we have difficulty finding out if they've gone somewhere else. So they may be lost to care, because we know some of those people are being seen by someone else. So we know that list may not mean that they're lost to care, they're just lost to that particular physician. And then, so now we're working with the center to try and find out if those people are actually on the antiretrovirals from somewhere else. And that's been our difficulty. So we're working through that problem now.
But no, that's a terrific approach to try to determine those who aren't in care at all, or again are in that moved or gone elsewhere category.
Right.
We love, right?
So we're kind of just stuck on that. We haven't even been able to access to the people who are lost yet before we're able to move to that step.
It's noble work you're doing, though, to figure out a process to do that. So we all thank you. Well, in the interest of time, I invite you all to think about and continue to think about the populations you're serving. What help do you need? What are you working on that's challenging you? And you heard wonderful suggestions from your colleagues today. A lot of great, I really appreciate your participation both on the phone and in the chat box to share what you're working on and what you're doing. And this is an example of how our collaboration in our HIV Continuum Collaborative can really benefit. So if you're working on something, chances are good someone else is too. So think about what assistance you need. Think about where you're stuck. Let's be sure to continue to communicate with each other and look for answers and reach out for the support of your wonderful colleagues here on the phone. And I think we have one more just gentle reminder that the reports are due today, and then I'll let Christina take the updates and next steps. Thanks, Christina.
Thanks, Kathy. This is a really great call, and I'm really happy to have been a part of this. I think it really points to some of these sort of thorny system-level changes, how challenging they can be, but how important we know they are. And I just wanted to come back briefly to some of the conversation around accessing data, because I know this is something that is challenging, certainly. And I do want to reassure you that there is a team in place at the center that is working on this issue. There's a committee in place, and it includes your medical health officers for each of the health authorities. And these things never move as fast as we want them to, but hopefully we'll have some good solid ideas about how to move forward with this as soon as possible. And in the meantime, I'd encourage you to connect, reach out to the faculty, to myself, if you're looking to explore some data that might be more useful to you in the short term. And with that, thank you so much, Kathy, for facilitating this call. Our next steps are, today is the reporting deadline, July 8th. The next reporting date is August 7th, and then our next monthly teleconference is August 12th. When we move forward into September, we initially had the next learning session planned for September 24th, but we're looking into now October. So we'll give you that date as soon as we have it. We're looking tentatively to October 22nd, so we're hoping that's going to work for everyone. And we'll give you more information about that as soon as we have that date confirmed. So thanks again, everyone, for joining us today. It's a beautiful day here in Vancouver. Hopefully it is where you are. Thank you so much, and have a wonderful rest of your day, and I look forward to your report.
Thank you.